My name is Tom Keene. I'm the National Coordinator for Health Information Technology, and we are going to be holding 3 roundtables to help us how to better understand to provide care for Americans with substance use disorder and mental health disorders. This is an area that is too often forgotten and that is not adequately addressed by our healthcare system. And our illustrious panel here today are all individuals who are deeply invested in changing that, in making sure that mental health and substance use care comes on to parity with traditional medical care so that all Americans can be treated. We will be going until about 4 this afternoon. The conference is being live streamed, and we expect this to be interactive. The purpose here is to learn and to make policy, so I want to thank you all for coming. I have a few opening remarks. Last December, President Trump signed the SUPPORT Act, reauthorization into law, and extended billions of dollars of federal funding for programs aimed at preventing overdoses and strengthening treatment and recovery services. Then, earlier this year, President Trump issued an executive order establishing the Great American Recovery Initiative, which sets the course for a national effort to prioritize addiction treatment and recovery. The Great American Recovery Initiative represents a first-of-its-kind, whole-of-government response to the disease of addiction, which impacts over 48 million Americans. As the National Coordinator for Health Information Technology, my office is charged with improving the access and use of electronic health information, including for mental health and substance use care. There are significant technological barriers impacting mental health and substance use care outcomes. I appreciate everyone joining us this morning to identify the challenges, highlight the successes, and to chart a path forward. As part of the SUPPORT Act reauthorization, my office is hosting this roundtable to inform a report to Congress speaking to how the adoption and use of electronic health records can improve mental health and substance use care outcomes. We are fortunate to have one of the 2 co-chairs of the Great American Recovery Initiative with us here today, who is also the White House Senior Advisor for Addiction Recovery, Catherine Burgum. From her time as First Lady of North Dakota to her current position as co-chair, Catherine has spent years working to eliminate the stigma associated with the disease of addiction to show people that there is hope for recovery. Catherine co-chairs the Great American Recovery Initiative with Secretary Kennedy, who is leading HHS efforts in the Great American Recovery and who will be speaking here later this afternoon. We also have former Congressman Patrick Kennedy here. Among his many accomplishments, he was the lead sponsor of the Mental Health Parity and Addiction Equity Act, signed into law almost 18 years ago. Sorry to date you, Congressman. And also here is Senator Roger Marshall, who is a physician and as a member of the Senate Help Committee has been an incredible advocate for addiction and recovery programs and access to coordinated, comprehensive behavioral health care. We have many other great leaders from across government and the private sector here today, bringing their unique perspectives to these important issues. As a practicing doctor and as the National Health Coordinator for Health IT, I cannot stress how important it is to have technologists and non-technologists involved in this conversation. Whole-of-person care and improved outcomes for patients cannot happen in the vacuum of a single doctor's office, a single electronic health record, or a single peer support group meeting. Healthcare technology must be leveraged to give patients and providers insights across care settings and to build connections between systems that are isolated. At ONC, our job is to make sure that healthcare technology enables safe and appropriate access, exchange, and use of electronic health data for both providers and patients. This means that a patient can download their medical records onto their phone, even if they are seen by 8 different providers. This means that a provider will have a patient's complete and accurate lab results before treating them. And this means that medical providers can communicate with housing and employment service providers to provide access to the 80% of recovery interventions that happen outside of the medical care system. The goal is not technology for its own sake. The goal is to use technology to improve access, affordability, and outcomes in all care settings. Mental health and substance use disorder care are just as much a part of a patient's health care as is health care for a patient's physical ailments. Patrick Kennedy helped pass legislation to make insurance companies treat it this way. Catherine Burgum has been fighting the stigma and shame that has prevented people from seeing addiction as the disease that it is. And Senator Marshall has been a tireless champion for legislation that supports the needs of patients suffering from mental health and substance use disorders. Their efforts are making a difference, and we will continue this work today. Unfortunately, the exchange of health data and adoption of electronic health records in mental health and substance use care lags. My office recently published a data brief analyzing a survey of mental health and substance use care providers done in conjunction with Chris Carroll and his team at SAMHSA. We found that most mental health and substance use care providers do have access to electronic health records, but only half use it routinely to send and receive data about their patients. With Secretary Kennedy's leadership, we are taking steps to change that. Together with SAMHSA, ONC launched the Behavioral Health Information Technology Initiative, a $20 million investment funding nationwide pilot programs with 45 exchange partners across 9 states. The BHIT initiative deploys 3 main work streams. First, it tests behavioral health specific data elements in real-world settings. Second, it pilots the exchange and use of these data elements in and across care settings. And third, it develops resources to scale the behavioral health data integration nationally. The initiative looks at the integration of treatment by acute medical providers with the services provided by housing, employment, and community health agencies. It looks at developing methods of computable consent so that sensitive health data can move privately and securely across electronic data systems with the proper patient consent. And it looks at leveraging technology to manage transitions of care so that patients do not fall through the cracks after acute care episodes. BHIT is a critical step towards breaking down the barriers currently impacting the interoperable exchange of behavioral health data across the care continuum. As ONC and the rest of HHS continues to work under Secretary Kennedy's leadership to drive the great American recovery, the insights and experiences you all share with us today will be crucial for our report writing and for understanding where gaps remain and for informing our future policy. Thank you again for being here today, and I look forward to candid and productive conversations. Thank you. So now I'd like to give the folks on the panel the opportunity to introduce themselves, tell us a little bit about yourselves and what your hopes both for this panel is and generally for the treatment of substance use disorder and mental health challenges. Actually, I'll start with you, Catherine. Please tell us a little bit about yourself.
Good morning. Super grateful to be here with you all. I am a woman in long-term recovery for over 24 years now. And I'll tell you a little bit more about that. No, we're going around to introductions first, right?
Why don't you tell us a little bit more about it?
Okay. Do you want me to do my whole speech?
You don't have to do your whole speech. You
Okay.
can give us a brief intro.
Okay. So I'm in long-term recovery, and my struggle with addiction started when I was in high school. Most of my life, I was struggling. Started when I was in high school. I guess where I would love to start with is just gratitude for everyone being here. And, I think that this disease is something that is decimating generations of people across our nation. So it affects me because I was someone who started drinking when I was in high school. I had my first blackout in high school. I started drinking because I had voices in my head that would tell me I was stupid. I needed to be perfect, and I couldn't make those voices go away. And then I took my first drink in high school, and they disappeared. And I was like, this is it. It's the solution. It's the answer to all my problems. And but then I had my first blackout in high school. And then I struggled with addiction to alcohol for over the next 20 years. I can share a little bit more in a while, or do you want me to just do my whole thing right now?
Well, I think that's a very powerful introduction. I'll ask you to share the full story in a little bit.
Okay.
But the generosity that you're showing in sharing your experience and understanding that sharing that experience can help others with addiction and recovery find their pathway to recovery. It's very powerful, and it's really a gift to all of us, and I can't thank you enough for that.
Thank you.
Congressman Kennedy.
Thank you so much, Dr. Keene and Catherine, for your leadership, and Senator Marshall and all my friends and colleagues who are pulling together an opportunity for us to address really the biggest, not sexy part of our challenge, which is data and interoperability and information technology. But in the very title, Dr. Keene of Office of National Coordinator, that's what we need. We need a national coordinator because what marks our illness is fragmentation and duplication and waste and awful outcomes because we've never deployed what works. But when I hear Dr. Keene talk about including those non-medical pieces to recovery, I'm excited because I believe, as Secretary Kennedy has said, that this is a threefold illness. As we say in recovery, it's a physical allergy, a mental obsession, and a spiritual malady. And as a threefold illness with a three-legged stool, you don't pull out one of the legs of the stool and expect the whole system to stand up. It needs all three. And the idea that we can start to assess these non-medical interventions for their value is really exciting to me and, frankly, my friends in recovery, because we could get another pill that can manage some symptoms, or we could get a stable place to live where we can develop new neural pathways of thinking and behaving because we have the support to really dive into our recovery, which includes a community support, a spiritual support, and, of course, mental health and addiction support. But none of this can be done in isolation, and that's why this idea of a national coordinator, all of your help in putting together pilots around the country for data exchange where we can test what works for whom. And the really exciting part about this endeavor is bringing personalized medicine to people with mental health and addiction issues. Every other area of medicine has standards of care except for mental health. You have cancer, you have cardiovascular disease, you have diabetes. No matter where you go in this country, you can expect to get standards of care, except for us. So wherever you show up, you're subject to the vagaries of where they are in delivering evidence-based treatment. And frankly, I'm here to tell you, over half the clinicians in this country, no fault of their own, but do not deliver simple cognitive behavioral therapy, which is the evidence form of treatment, because they had never gotten that kind of specified type of training that's appropriate for the clinical diagnoses that they're treating. And it's not a one-size-fits-all illness, even though to this day we treat all of these diagnoses as if they're the same. Now, in general, they all benefit from some of the same elements. But like every other disease, like specific types of other illnesses, we do not have anything close to personalized medicine, let alone the implementation of standards of care. So we need that. When Senator Marshall, when I was in Congress, we worked to try to get the electronic health record to include mental health and subsidize behavioral health providers so that they could afford to put the infrastructure in place to be able to do this data sharing. We never were successful to doing that. I had the chance to talk to Theo Merkel from the Domestic Policy Council. He said, I don't think the administration is going to dive in and subsidize these big technology companies anymore. So we have to come up with an alternative. And frankly, the president's transparency law and transparency rule also gives us another tool to assess what's working and what's not. And I'm proud to say the Kennedy Forum just released the Parity Index, which uses President Trump's publicly available data, thanks to that law, and assesses where all insurance companies are in terms of their claims data and what they have in-network versus what they have out-of-network. Now we got to dig into that same accountability when it comes to providers. We have a lot of stranded costs in the medical system. Those costs are not getting people better, as the Secretary has said. We have a goal of getting chronic illness addressed in this country, and at the end of the day, what I hope can come from this is that there's no MAHA without mental health. You cannot treat any of the chronic illnesses that are the goal of this administration if mental health is not integral in terms of the treatment of those illnesses. I'll conclude with this. I am a person in long-term recovery as well. I've been at 8 different rehabs. I racked up every kind of bill in the emergency room you could rack up. And I will tell you, in the last 15 plus years I've been in long-term recovery, I've not had to visit the ER once. And I tell my Horizon Blue Cross plan in New Jersey they ought to scratch a big check to my 12-step recovery group because that's been the key to me not ending back up in the ER. Save the system millions of dollars in the last 15 years. And I believe that while we're coming up with the data help us make better decisions, let's also not wait to do what we already know works. Let's do specialty coordinated care as a mandate. Our Office of National Policy Personnel, we ought to put that in the RFP. Let's do collaborative care codes. We already know that is essential to integrating primary care and mental health. And frankly, 80% of the antipsychotropics, antidepressants, all written by primary care docs, often with no input from specialty psychiatrists and the like. So let's do those things we know work while we're building the infrastructure to understand new ways of making the system work even better. Thanks for letting me share.
And thank you for sharing. Those are very powerful words. And what I can say is it is our goal that where we have had fits and starts before during this administration, we're going to actually cross the finish line. The only thing I would quibble with that you said is at the beginning you said that data is not sexy. As the guy who oversees health data, I would say it's very sexy. Senator Marshall, you've been a tireless advocate for patients with mental health and substance use disorder specifically and for patients in general. Love to hear from you.
Sure. Thanks, Dr. King. Thanks for hosting us. We lose more farmers every year to suicide than farm accidents. Let me say that again. We lose more farmers every year to suicide than farming accidents. On the other end of the spectrum, we have an epidemic of mental health issues in children, and of course that's going to lead to more abuse as well. We have to get at the root of the problem rather than just throwing new medication at it. I want to just stop and praise the things that are working. On the farmer side of this, Kansas State Extension, Kansas Farm Bureau, Kansas Corn, the ag lenders, especially the farm credit institutions, they know the at-risk people. They know who the at-risk people are, so we're trying to identify them and then remove the stigma of getting mental health. Now, how do you do that? Look, if I pull up in my Dodge Ram truck, everyone in my hometown knows it's me. So, if I pull up in front of the mental health center, there'll be that stigma. But if it's embedded within the other primary care clinics, then people are there, maybe I'm getting my blood pressure checked, So what's working in Kansas are our CCBHCs, Certified Community Behavioral Health Clinics. We have 28 of them. And they've embedded primary care within those clinics. And it's bringing MAHA to people where they are. Bring in the nutritionist, bring in the food bank, bring in WIC, bring in nurse coaches. So those are working along with our community health centers, FQHCs. We have 32 of those, and I bet there's probably more than that in the number of clinics. And then we have rural health clinics that are subsidized by the federal government as well. And I have a saying, if you can't measure it, you can't manage it. So right now we have 25 different EMRs and 25 different paths, and it's how do we bring those all into one entity? It's my belief that we need one EMR and we need one dashboard that works for all of them. I mean, it's got to be so simple. Look, I led our hospital through Meaningful Use 1 and 2, as well as our doctor's clinic, the worst chore I've ever had in my life. And the only thing sure about whichever record you picked as a doctor when the federal government threw money at is that the doctor switched in 3 months because they didn't like that one. So throwing money at it is not the solution. Whether you're a veteran or you're a soldier or you're an employee of the government or you're getting health care through a rural health clinic or through CBOCs or CCBHCs, we need one EMR. They never are going to communicate with each other. The makers of these do not want them to communicate to each other. The federal government has to say, this is the one, and if you don't communicate with it, you're done. And we're gonna, and you owe us money. That would be my attitude towards this. We can't be a slave to the data either. We took nurses off the floor to turn them into data entry people with Meaningful Use 1 and Meaningful Use 2. So it has to be really simple. And you know, I've been asking my community health centers for 7-8 years to give me one dashboard. You know, to me, mental illness is one of the 9 chronic diseases that drives 85% of the spend on health care. So mental health needs its dashboard, just like hypertension needs a dashboard. And guess what? People with mental health may also have diabetes and hypertension and poor nutrition. So I think that let's not reinvent the wheel. Let's not start another program. Let's accentuate what's working and bring them all together and rely on these beautiful numbers to help guide us. I say if you've seen one community health center, you've seen one. And some are great and some aren't busy, but we should be standard metrics that is so simple that the 7-second attention span of a senator, which is even less than an orthopedic surgeon, could look at this dashboard in just a matter of seconds and say, this clinic is doing a good job. Thanks.
Thanks for those powerful words, and I think that your experience as a physician and as a senator and policymaker really allow you to understand how the rubber hits the road with the policies that you make. And maybe later we can discuss what the attention span of an OB-GYN is compared to those of the orthopedic surgeons. Dr. Klein, you are the head of ARC. Please tell us about yourself.
Yeah, I'm Roger Klein. I'm a physician and an attorney, and I direct the Agency for Healthcare Research and Quality. So listening to Patrick's comments really were inspiring because what he's talking about is exactly what our agency does. I'm a native Ohioan, and so I've seen what the opioid crisis has done in our state. It's devastated, especially our rural communities. But our agency looks at finding out what works and what doesn't. That's our mission. And then we make sure that the knowledge is safely implemented, that it's effectively implemented, and that access is provided for all. And that's what. So what you're speaking about, you know, in terms of behavioral health, we have primary care. You mentioned we have what's called our Integration Academy. And that's dedicated toward bringing behavioral health into primary care settings. And so we have an entire program centered around that. And then we do a lot, both in hospital and outside the hospital in terms of quality. And then we're getting into we've done some level of effectiveness work in this area, and with your inspiration, we're going to be doing more. So that we can really find out and understand what are the best ways to manage people, the best ways to treat people, and then make sure that that's actually done. I mean, we work at the bedside. We're right there implementing care. We're not doing high level research. We're not looking at receptors and all kinds of things. We're not doing basic science. What we're doing is we're implementing. We're doing research on the best ways to implement medical care and improve outcomes for everybody.
Thank you, Dr. Klein. Mr. Carroll.
I'll see if I can bring the room down a little bit after all those dynamic speakers, and that's definitely a possibility. Thank you, Senator Marshall, Tom, Ken, Carissa, all my colleagues around here, especially Patrick. I was thinking about this over the weekend and my remarks, and I thought back to one of the first things I did in my professional career at SAMHSA is I wrote an article. I published an article in the International Journal of Mental Health called "Information Technology and Performance Measures as Transformational Strategies." And I went back and I read it. I was right. They are. But the problem is I wrote it in 2005. So, we've been talking about this for a long time. And I'm excited because we now have the opportunity to actually do something. So, and the time is now, actually. So, the reality is people just are not getting better. We've not made the progress that we need to make. 1 in 6 people have a substance use disorder. A quarter of adults experienced a mental illness last year. A quarter. Among those, nearly half had a substance use disorder as well. And too many people that need treatment do not get it. And all of this is costing us billions of dollars a year. So there's an economic issue at play here too. This is important work to me. I think everybody in this room, I know everybody in this room, either knows someone, loves someone, or are someone with one of these conditions. That is 100% true. So, through our partnership with ONC, which I'm thankful for, we're working to change this trajectory. We're focusing on solutions that get at the root of the problems. It's not rocket science. It's transactional. It's in some ways easy. I don't understand why we haven't done it yet. But more than that, I'm grateful for the administration's focus on recovery, for Catherine's work. I'm grateful to the Secretary. He has both a professional and personal commitment to recovery. And I look forward to this conversation today. We can take what we learn and use it. So thank you, Tom.
Thank you, Mr. Carroll. And for what it's worth, I think your words are just as inspiring as everybody else's on the panel. And our collaboration both with ARC and SAMHSA has been fantastic. It's really making real changes. So thank you for that. Sam.
Thanks, Tom, and I'll keep it brief. Sam Cardall, I'm one of Dr. Keene's deputies at ONC, and I just want to echo something that Tom said in his remarks, that the Office of National Coordinator, it's not simply about technology for the sake of technology. It's about how technology can improve access and outcomes for folks, especially today's topic, mental health and substance use care. So I appreciate everyone being here and their engagement, because national coordinating is hard when it's just doing it by yourself. You need to coordinate a bunch of people to get real positive outcomes. So thank you.
And we want to thank everybody here for collaborating with us. To Sam's point, Carissa.
Hi, good morning. Thank you very much for having me here. I have, I think, the unique opportunity to be here at the table today. My experience is a little bit different than everyone else's. I've had the opportunity to see this literally from all sides. I grew up in a town of 1,000 people where I had a clinic next to a pharmacy, next to a hospital, next to a therapist. All they had to do was pick up the phone or walk 2 doors down, and all of that information was shared. When I went to college and then I went to my pharmacy, complete my pharmacy degree, I was surprised that not everybody had that experience. And as I went through my career, my heart just got a little bit sadder and sadder every step, where I got to see the system just fall apart. So I'm a counselor here at HHS, and I get to support HRSA, SAMHSA, ACF, and ACL. Unique opportunity. I think that they work in partnership. That means it's holistic care. It's caring for the person from start to finish. I have a father-in-law who is a farmer, and he has lost quite a few of friends to mental health. And so finding a way to not just talk about integrating through EMRs, but also finding ways to make it easier to use telehealth for smart phrases, for dot phrases, whatever it is that we can do within those EMR systems to make it simple to document what they have learned from that person. I have family members that live in assisted livings for mental health. Every time they hit the ER, they start over because the information, the medications that they've been on are absolutely just not shared. I was a director of pharmacy at an academic medical institution when we did a rip and replace of our EMR system, and it was a really big conversation at that time. Do we put the mental health information in the same EMR as everything else? And at that time, we literally thought there were some rules that didn't allow us to do that we would get in trouble if we did that. So some of that really is just education, and I appreciate the conversation today because I do think we can do it better. I started back in the day when you would discharge somebody from the hospital on Coumadin. The physician didn't know, the family practice physician, maybe what the INR was when they were discharged. And so understanding how they should adjust those medications, we figured out how to solve it. We did. And that was before we had electronic medical records that spoke across all of the different disciplines. I do believe we can do this now. And I think it's individuals in this room and on this panel that are dedicated to it. We will see it happen. We will.
Thank you. And I appreciate the comments of folks who live and represent rural communities. I had practiced in a rural community for 6 years, and I know the specific challenges that they face, even above and beyond the challenges that all of American healthcare faces. Mr. Callahan.
Thanks, Dr. Keene. And yeah, just will echo what everyone has said, the gratitude, and thank you everyone for being here. My name is Ken Callahan, head of policy for Secretary Kennedy, and this has been a top priority for him. He's asked every agency at the department to see what can be done, and he's already, as you've seen, he's already announced a number of different policy announcements on increasing sober housing services to working more with faith-based providers, but all of those initiatives are going to take better data and better coordination, and it's very imperative that all the providers and all the patients have the best data that they have. So this will fit very well into the Make America Healthy Again initiative, and as Patrick mentioned before, they go hand in hand, and it's going to continue to be a top priority for the Secretary moving forward. Growing up in Ohio, I had too many friends that suffered from this, either getting access to opioids that they weren't prescribed or being, getting addicted one way or another. So seeing the progress that's been made is good, but to Chris's point earlier, there still needs to be a lot more progress. So this is going to continue to be a top priority, and just happy to be part of the conversation today.
Thanks, Ken. Mr. Krugen.
Thanks. It's a privilege to be here. So I'm an internal medicine doctor. I trained in the primary care track and firmly believe that PCPs need to be a part of this solution. I still see patients with addiction medicine. Can you guys hear me? Okay, good. 1 day a week, I see patients with addiction in a rural safety net clinic, and then I'm the deputy secretary at the Louisiana Department of Health. We don't need to look far to see the implications when we can't meet the need of our patients. I was up late last night sorting through this horrific shooting in Shreveport. I think at the same time, for every one of those instances, there's incredible examples of durable, long-term, dramatic recovery, and it's all about helping folks move into that second category. So looking forward to learning from folks on this panel and sharing a little bit more about what Louisiana is doing later.
Great, thank you. Tracy.
Good morning. Thank you so much for having me here. Tracy Gruber, the Executive Director at the Utah Department of Health and Human Services. This is a data conference, or roundtable, so why this is so important to our state starts with the data. We have been looking at our all payers claims database. In the state, we know that we have 20% of our adults having behavioral health challenges with the diagnosis. 24% of our youth have a high need for mental health treatment, and 30% are living with a mental illness. We know that this is incredibly important. Also, unfortunately, high rates of suicide and how you address those issues. And we also know that the relationship between behavioral health, physical health, and outcomes is interlinked. And I'm honored to be representing a state and a department that has the ability to bring together an individual holistically from their behavioral health needs and their physical health needs, have the resources to bear to address those and improve outcomes. And I'm so grateful for this convening today, because when us at the state level have to balance the various divisions and entities within HHS and the funding sources and all the different requirements, to have so many of the HHS entities here today for this conversation gives me hope as an administrator at the state level that we're going to solve this, because the only way we're going to be able to do it is by working together. I also have a personal challenge with mental health that started when I was in college, and every time I go to the doctor, I have to have the same conversation. I'm blessed to have good health care, my profession and my life is the result of having that good health care, and I think everyone should have it, and having a conversation about the non-sexy part. Dr. Keene, I'm with you. I think this is a critically important element that needs to be resolved, and really hopeful for the start of that happening today. So thank you.
Thank you. And we know that Utah and Louisiana are very forward-looking states on these issues and on the issues of technology generally. Ms. Moretti, you want to tell us about Ohio?
Well, it sounds like there's lots of Ohio love in here today, so that's unusual, but amazing. I'll take it. I am Tia Marcel Moretti, the director of the Department of Behavioral Health in Ohio, which is a standalone cabinet agency representing 6 state psychiatric hospitals. So that's over 1,000 patients in our hospitals at any given point, in addition to all of behavioral health in terms of addiction, mental health, and SMI. And as many know, Governor DeWine made behavioral health his priority within the reflecting of his first 3 executive orders. One was to create Recovery Ohio, which is an agency that coordinates all the agencies to take efforts toward recovery in Ohio. And then the next was Children's Initiatives, doing the same thing, having us all rowing in the same direction and collaborating as sister agencies around children's issues. As we know, so many were victims of and continue to be victims, as is reflected in youth mental health, of the opioid epidemic. And then the last was to create an appointed position for the Deputy of Prevention Services. So just marking that these were those priorities for him. And as we round out in less than 200 days left in the administration, I'm honored to have served multiple times. I am a licensed social worker, so a clinician and a certified prevention consultant. My background, in addition to counseling, has been in Medicaid as a senior advisor in private equity in their healthcare portfolios, as well as an executive at an MCO. So when I was asked to come back and lead this agency, I'm deeply passionate about increasing the business acumen of behavioral health, because healthcare and behavioral health is healthcare, but healthcare is a business. And we've been able to justify outcomes and metrics in many other areas, just as you had said, sir. And why can't we expect that in behavioral health? And often I see that we are paying for activities and not outcomes, where if we could elevate our data to a platform that was interoperable, we could operate in a grant environment, much like claims adjudication, so that we can see the whole picture and not have the blind spots of transition of care and be able to calculate total cost of care in grant-making environments. So needless to say, a little bit passionate about making this a business enterprise, and largely driven by having been born in withdrawal and told that I would be developmentally disabled, 3 stints in foster care, and then ultimately being homeless and alone my senior year in high school. So I'm here because these stories matter, and my mom didn't get what she needed, and largely that's because there were no accountabilities in this system. So thank you so much for having Ohio. Thank you so much for having Ohioans around the table, and I'm so looking forward to being a contributing partner. Thank you, Dr. Keene.
Thank you. And I just found out that Ms. Moretti's family owns the Moretti's restaurant, 2 restaurants in Columbus, Ohio, at least one of which I've eaten at before. And I suggest that we all convene after this at Moretti's and have a discussion about how sexy health data is. So thank you, everybody, for those wonderful introductions and for telling us what your investment in these activities are. Now I'd like to go around and ask some folks specific questions, and I'm going to start with you, Catherine. You were the former First Lady of North Dakota, and you are the Senior Advisor at the White House for Addiction and Recovery. Would you tell us your story?
Okay, sure. So great to hear everyone around this table and to see everyone here so invested in this topic of mental health or addiction, which is really just health, I believe. And so anyway, again, I'm starting to call it Mega Maha because Maha is really everywhere, right? And it's in the data, it's everywhere. So Secretary Kennedy says that addiction begins in isolation and ends in reconnection. And, I did live that. I started to share my story, but I almost didn't make it to the second half because at the end of my drinking, I was suicidal, and the shame and stigma made me think that I didn't deserve to get help. And I talked a little bit about my story starting in high school, and that I'm in recovery now long term. But what happened for me was I was out walking. At the end of my drinking, I didn't know what else to do. I was trying to stay sober. I couldn't do it. I'd been to treatment, and I just didn't have a lot of faith. I wasn't part of organized religion, but I knew there was a God, and I just said, hey, if anyone is there, I need help. And I have been sober since I uttered those words. And so I love that this administration has faith as a part of what we do and what everybody's doing, because it was a big part of the reason why I'm here today. When I became First Lady of North Dakota, I'd been in recovery for 15 years, but I didn't talk about it. So all those years of struggle and being in recovery, nobody knew, and I didn't talk about it, but it was the height of the opioid crisis. It was the first Trump administration, and I decided that, it was going to take some courage, but if I could help one person by sharing my story, it would be worth it. So I opened that door, a bunch of weight got lifted off my shoulders, and then it opened 1,000 more doors and led me to here, seated at this table with all of you, working on these really important topics. So when I became First Lady, I decided to focus on eliminating the stigma of addiction. So we started something called Recovery Reinvented, which was a one-day event solely focused on stigma and eliminating stigma. And it was all about storytelling. And we had scientists and a bunch of other people coming to that event. And that turned into a movement in our state. My husband and I emceed it every year for 8 years. And I wasn't sure if it was working until the first, maybe 2 years into doing it, the second or third year. Someone on my team said these people wanted to meet with me, so I did, and they had come to Recovery Reinvented, and they were sharing the story with me of how they revived their son at their home with the Narcan that we trained them with and gave them for free. And so I thought, wow, that's the one person, that got help. But then at the end of my being First Lady, this wonderful mother and her 3 kids, and then her mom, the grandma, all came up to us. It was Halloween. We were giving out candy at the governor's residence. And she said, I really wanted to be here and meet you, this mother of these 3 kids. And she said, because my mother brought me to Recovery Reinvented, and I couldn't get sober, and I lost my kids and everything. And at that point, she was now in recovery for 4 years and has her kids. And it was just, I was like, wow, to see these people bringing their lives back together because of this event that we started to do. So that was, fantastic. People are talking about statistics. And many of you have heard this one from a 2024 survey that says 40.7 million Americans with substance use disorder, 95% didn't perceive they needed the treatment, and 50 to 70% of that is driven directly or indirectly by stigma. And stigma isn't a side effect of this disease. It's the disease's most powerful ally, which is why I'm so grateful that President Trump created the executive order establishing the Great American Recovery Initiative to fight this. It directs us to focus on a culture that celebrates recovery, because you can't coordinate care for people who don't believe they deserve it. So in North Dakota, related to stigma, we created 3 pillars. Storytelling, which I've talked about, but we measured stigma in our state because people were saying, I feel like, things are changing. More people are talking about addiction. And so I was like, well, feelings are one thing, but data moves the needle, gets funding, and creates awareness. So over a 3-year span, just through storytelling, without any taxpayer dollars, we reduced stigma by 20%. So and then I met with the head of the CDC during the first Trump administration. I'm like, you guys are the surveillance team. You should be measuring stigma in every single state across the nation. He didn't do that, but he said he would think about it. But anyway, then the other thing we've done in North Dakota, what we did was, because we're a 50% rural state, we're never going to have services for all the people that needed it across North Dakota. So we doubled down on the peer support program. And today we have over 2,000 peer supports trained in our state. We have 5 tribes we share geography with, and a significant majority of the peers in our state are from the tribes because their services are so significantly lacking. So I love this. I love to say, which we should have a T-shirt made with this saying, that lived experience is a credential, not a disqualification. Then we created another program called Free Through Recovery, which was funded by the state to reduce recidivism, and it paired peer supports with people coming out of the criminal justice system. That was a super successful program in our state. Because we legally discriminate against people with felonies in our country, and they can't get a job, and this peer support opportunity is so important. And from the technology front, in states like North Dakota, with Recovery Reinvented, we were able to broadcast that behind prison walls. People in Portugal and South Africa saw that program. So technology is hugely important. Telehealth is so important for rural states. So from that perspective, technology is a big tool that we used in North Dakota. But let's move to the Great American Recovery, which I'm so excited about. And I'd love to thank President Trump again for signing the executive order. He used that authority of the presidency to declare what every person in recovery has needed to hear from the highest level of government, that addiction is a chronic, relapsing, lifelong disease. It's a chronic disease. And it's in the executive order. So if from the highest office in the land, and if we don't treat it, it's a fatal disease. So it's like diabetes and all the other chronic diseases. So, so for those 95.6% of the people who didn't perceive they need help, when the President of the United States declares addiction a chronic disease, the word disease itself helps to eliminate stigma. The disease framing for addiction can reduce stigma-related barriers by 20 to 30% as compared to disorder. So anyway, when we're going to focus on the full continuum of care with Great American Recovery, we talk about integrating prevention, early intervention, treatment, and recovery supports and reentry. We try to solve addiction at the crisis moment. And then that's when we get involved, and then we focus on all the consequences, and we layer and layer and layer and layer programs on top of the consequences. And that has to change. This is a chronic disease, so we need a full continuum of care focused on a chronic disease model. And also we need cross-agency coordination, which is exactly what we'll be focusing on across cabinets. And then the other part of the executive order talks about celebrating recovery. So the more we do that, the more we lift up the people in recovery, the more people will see that people do recover from this, and they lead lives, very successful lives, and they all can look just like you and me. So, one of the things I've learned is that 113 million people in America are affected by someone else's disease and someone else's addiction. 113 million people. And then there's 48 million people with the disease of addiction. So add up the numbers, it's half our nation is struggling because they're impacted in some way by the disease of addiction. And so we are going to focus very heavily on chronic disease because that is, in my opinion, what needs to change. I mean, it's a big lift. Obviously, everybody's talking about codes and this and that and how do we do it, but it's a chronic disease. Let's just call a spade and start focusing on that and change our health care so these people are fully wrapped in a continuum of care and there's no gaps in the system for people to fall through. And so anyway, I'm grateful that I have the opportunity to co-chair this initiative with Bobby, two people with lived experience. Anyway, I just sometimes I wake up every morning saying, I can't believe I have this opportunity. So we're going to do our best to save lives across America.
Well, I think I speak for everybody when I say thank you for turning your lived experience into something that can be leveraged by other folks facing the same issues. It seems like you did extraordinary work when you were in North Dakota and are now scaling that up nationwide, and we can't thank you enough for it. I mean, even that one life saved by the interdiction of Narcan is an entire family and life changed. And maybe it's not 119 million, it's 118,999,000 that are impacted by this disease, and we can't thank you enough for your contribution. Patrick, you also have lived at the intersection of lived experience and policy. When it comes to the exchange of health data, in what ways do you think that behavioral health is still falling short, and what are the ways that federal and state leaders can change this?
Well, first of all, let me thank Catherine for your remarks, especially as it relates to this is not just a healthcare issue. When you brought up the criminal justice system, we all know that unfortunately the largest psychiatric hospital systems in this country are county jails and prisons. And that is because we have not done an adequate job at understanding the intersection of a public health model that leaves out the total cost of care, as Secretary Moretti said. If the total cost of care is not just the medical cost, it's the criminal justice cost. It's the foster care cost. It's the housing, human services cost. Lots of these costs are spread throughout the government, federal level, state level, county, and local. If we were ever able to truly track those downstream costs of not adequately moving upstream and preventing these illnesses, there would be a no-brainer in terms of moving the dollars away from this acute episodic treatment system. As I said, Catherine, 8 separate rehabs, huge costs. After each one, no coordination of care for me. My docs never understood. This was before the prescription drug monitoring program, too. So I could, to the pharmacy issue, Carissa, get my opioids filled, Oxycontin everywhere. But when I first went to the doctor to get my checkup, they'd ask me, is there a family history of cardiovascular disease? Yup. I got Lipitor in like my 30s. Okay, because they wanted to save my life when I'm in my 60s and 70s. That's a healthcare system that wants to go upstream. When I go to my doctor, he takes one look at my Irish face and he says, ooh, I bet you could use a dermatologist. And he's right. I've got a lot of risk factors there. But the doctor never asked, do you come from a family of addiction? Imagine if you were able to truly track these, as you said, Senator Marshall, in a totally unjudgmental, unbiased, purely normative way, and say, okay, you're high risk. You come from a family of addiction, trauma, major contributor. and Peter. Our hearts go out to Louisiana, all the people, all those parents and siblings and children who are suffering today because of that horrendous trauma. I guarantee if we don't treat them early and wrap our arms around them, the ripple effect of that trauma will be felt not only throughout their lives and their families' lives, but their whole community's lives. And Secretary Kennedy and I both understand that. The trauma of his father's assassination, my uncles, and so forth, have made their way through generations of my cousins. And so we had better in this nation address this as a family issue, not just an individual issue. And all of this is possible now that we have data at a level that we've never been able to do before, so we can track population data in addition to individual data. And that, Dr. Keene, would be one of my recommendations to that point of surveillance, Catherine, about CDC. We know who is at risk. Why aren't we moving upstream and risk stratifying those populations? So we're not doing a one-size-fits-all and putting a whole bunch of money. Focus the money where we know it'll do the most good. And so if we're not tracking those highest utilizers of our jails and our Medicaid system, the taxpayer's paying for this. They're just paying for it through different pockets, so no one gets the complete picture. So, Catherine, one of the things that I hope with your leadership, to your point on the criminal justice side, we can begin with pilots that aren't hard to start with. We don't need Dr. Keene, you to jump in just yet. There's enough data right now to tell us what we should be doing while we're working to enhance our ability to collect the proper data more writ large. But anyway, I have felt so grateful, as you said, Catherine, to be part of this initiative. And I can tell you from personal experience, there's so many areas that we need to start to connect the dots, and I know everyone's echoed that. So I'll shut up now and let others. There's a famous phrase that everything's been said, but not everyone's said it yet. But as Senator Marshall, you said, you can't manage what you can't measure. And how are we going to measure things if we don't have the data? So it comes back to that. If we want to save money, we need to spend money on getting the infrastructure in place. We don't have to spend a lot of money, but we have to understand that if we put an infrastructure in place to track this data through Dr. Keene, your leadership, and Dr. Oz, frankly, because we need where the money comes from to be pushing these solutions. So I'm excited to be part of this and thrilled to join all of you in trying to push it forward.
Thank you, and I think what you've just said hasn't been said before, so I appreciate you saying it.
Thank you.
Senator Marshall, as a physician representing a largely rural state, what are some of the specific challenges regarding access to mental health and substance use care in rural America, and how do you see technology playing a role in addressing some of these gaps?
Yeah, thanks, Dr. Keene. I mentioned farmers' health and farmer suicide earlier. I want to talk about children just a little bit more. Whether you're in rural America, urban America, suburban America, we're seeing an epidemic of mental health challenges in our children. Encourage everyone to read The Anxious Generation if they haven't, and I think social media is a big part of that. I'm on this mission to salute people that are doing a good job, and I want to stop and salute Facebook and Meta and what they're doing with Instagram. That they have, and I'm going to use my notes here, teen accounts with built-in restrictions, stricter content controls of PG-13 style, limits on risky interactions, AI enforcements against predators. And I'm just calling on all social media, especially the TikToks of the world, to do the same. But I don't have confidence, and that means Congress needs to act. And how do we set those guardrails without, hurting people's privacy? But it's that bad, again, regardless of where you are. So I think that would be one issue. Then speak to OB, my specialty. I delivered a baby most every day for 25 years. When I was practicing, the largest cause of maternal deaths were the typical things like hypertension and stroke and embolic phenomena, hemorrhaging, infection, But today, now remember, maternal mortality is measured for a year after delivery. The number one killer is suicide and drug overdose / poisoning. Fentanyl is typically poisoning. Those are accidental deaths. They're not trying to overdose, right? So that's the big picture again, whether you're in rural America or in urban America. I think we have to continue to accentuate the positive, what's working, and work with those organizations that I described. But remember this, people solve the problems. A loving nurse, a caring doctor, nutrition coaches, they're the ones that solve the problems. Data, we don't want to be the slave to data, is what I'm trying to say. That's why I go back to my dashboards, a very simple dashboard as opposed to we have too much data, and that's when we're going to bring in AI as well. And I wanted to emphasize that I've yet to meet a doctor yet that likes their EMR. And the doctors now spend their lunch breaks, they take records home and spend hours a day because of the EMR. They become a slave to that data, but it really has not improved health care. It starts with a very simple problem list. My old paper records, I kept a problem list on the front page. Tobacco, osteoporosis, hypertension, whatever it was. And just in a snapshot, I could walk in the room and have all that, and then look at the patient and sit down and look him in the eye and say, tell me what's going on. And instead, young doctors and nurses, this is what they're doing when the patient's talking. So it's so sad. It's so sad. So don't let us become a slave to this data. Keep it simple. Use AI. Use AI to bring the data, to collate the data, to make it meaningful, and then to make suggestions to the practitioners. Give it to those nurse coaches. My best person I ever had at diabetics, and we had a very large OB diabetic clinic, unfortunately, was an LPN. And it wasn't because she knew more about nutrition than anybody else. It's because she loved on those mamas, more like a grandma or a favorite auntie, and coached them up. You're expecting me to talk about telemedicine, which is important. And telemedicine works after you have the relationship. But it starts with that relationship. And we have to, again, embed all of this together. That's why it works in rural America, in urban America, and suburban America, is embedding it all together. Rural America, we have the internet connections now. So don't let them tell you otherwise. There's a few places where the phones don't work, but there's places that almost anywhere across the state of Kansas that you have access to the internet. But I think it's more that, the challenge is engaging that farmer, is removing the stigma. How do you start the process? That's the challenge. How do we empower them? And then how do we bring in the rest of the MAHA, the nutrition coaching? I don't care what mental illness you have or addiction you have. If you have poor nutrition, it exacerbates it. So treating patients, this whole patient, embedding them all together. And again, those pieces are out there. How do we collate them? It's got to be one EMR. This has to be the dashboard. And if you don't want to comply with that, then we're not going to give you federal dollars. Thanks.
Senator Marshall, thank you for calling out an area of mental health that is often forgotten, childhood mental health. And thank you for doing so much in the Senate to see that this issue is addressed. And I can tell you that at our agency, we take very seriously the burden that EMRs impose on patients. I still practice, and so I get to go from being the person who regulates the EMR to the person who suffers under the EMR on a pretty routine basis. Mm-hmm. So we're taking it very seriously, and we appreciate your attention to it.
Suffering's the right word.
Dr. Klein, how can we use technology to better integrate mental health and substance use treatment into primary care settings, and why is it important for improving quality and outcomes for patients?
Yeah, thanks, Tom. That's a great question, and I would point back to what Senator Marshall just said about relationships And I think the importance stems from that relationship. And so as Congressman Kennedy said, 80% of antidepressant or psychotropic prescriptions are given in primary care settings. Most patients with depression are treated in primary care settings, but most patients actually are not treated with either drugs or medicines. It's a gap. Many patients don't refill their prescriptions, and slightly over half return for a second therapy visit. So there are clearly holes here. The numbers for anxiety disorders are even less encouraging. Most patients who are treated are seen in primary care settings, but diagnoses are often missed. It's actually quite infrequent to diagnose an anxiety disorder, even though that's where the patients are seen. And so most are untreated. Substance abuse treatment actually is not common in primary care, and perhaps Dr. Krugen can discuss some of the reasons for that. But I think the principles in terms of technology implementation remain the same for as with other behavioral disorders. And so what can technology do? It can help primary care doctors identify mental health needs early. Key, identify mental health needs early, connect patients to care teams, monitor progress, and then potentially extend access. So looking at the EMR is problematic, but it's also a tool for good. And so we can implement, we can take standardized screening tools, and we can add them, embed them into EHRs to encourage routine screening, just as we do with other illnesses. And then we can use the clinical decision tools that can prompt providers with diagnoses. Hey, this patient looks like they're having an issue, and suggest potential interventions or referrals. Technology can help us bring through registries and dashboards and clinical decision support tools. It can enable measurement-based care if you have to measure it. So that means tracking symptoms, treatment response, follow-up, and risk over time, adjusting care quickly when a patient isn't improving. So all of this technology can help us do all of these things, and this is critical in a busy primary care setting. The primary care doctors nowadays they're called upon to do many things, and it's extremely challenging. And I think technologies are a great friend here. Technology can also support team-based coordinated care. We can have shared health plans, shared care plans, electronic referrals, and secure communication, so that primary care physicians and managers and behavioral health specialists have access to the same information. So it helps integrate the function of behavior. Even if it's not in the same setting, it helps integrate the function of behavioral health with primary care. And telehealth was mentioned, e-consults and digital tools. They can expand access to mental health and substance use services, especially in rural communities or other places where you don't have specialty care. And then, so Senator Marshall mentioned AI, and I think this is really one of the exciting new areas. At least I find it very fascinating. So you can use predictive analytics to potentially identify patients who are, for example, at risk for suicide, or overdose, or relapse. So using AI to analyze the data, we can see patterns that maybe we wouldn't recognize as doctors. And it will enable us to provide better care. As I think was generally recognized, mental health care and substance use conditions are intertwined with physical health. When they're unrecognized or untreated, patients are less likely, for example, to manage chronic diseases. They're less likely to adhere to medications. They're more likely to experience crisis care, hospitalizations, overdoses, or worse. Primary care is where most patients already are, and integrating these services helps improve early identification, continuity, access, and follow-through. All the while, Secretary Burgum, while reducing stigma and fragmentation. So stigma. I think integrating these services into primary care, as you pointed out, and I think others have mentioned, does help reduce the stigma. So at AHRQ, our role in this journey has been to define and test these approaches in real-world settings through research, through our Integration Academy, and through implementation tools that we develop that we give to doctors and health systems and other providers in order to take the knowledge that we've gained and distribute it outward to patients.
Thank you, Dr. Klein. And your point about measurement is extremely well taken. It's something that I look forward to collaborating with ARC on. Your agency has done extraordinary things in physical health, more or less eliminating central line infections over the last 20 years. And under your leadership, I think we'll be able to do the same thing for mental health. Christopher, could you tell us about some of the work that SAMHSA is doing in support of the Great American Recovery? And what role does data interoperability play in improving mental health and substance use care outcomes?
Thank you, Tom. First, I'd like to thank Catherine for all of her leadership. It's been a pleasure getting to know you, and your drive is amazing. So thank you for your work. So this, it's interesting that, you know, recovery's always been a very clear marker for SAMHSA. We've believed in recovery for years and years and years. In fact, we have an Office of Recovery. It's the only office in the federal government that's fully staffed by people in recovery. So this is, you know, we kind of feel like the church kind of turned around to us and said, oh, there you are, right? And that provides us an amazing platform, I think, for SAMHSA. And I think the secretary started that when he came in. He really inspired us. And then the president solidified that through his executive orders on the Great American Recovery Initiative. Just to be clear, through these executive orders and what I've hoped SAMHSA would do is to execute our portfolio to support those initiatives and do that with compassion. And I think we are doing that. This provides us another opportunity to do that, so I'm looking forward to that. We have been, what I have found to be a nice endeavor is working with my colleagues in HRSA and ARC and CMS and HRSA and seeing their commitment and passion as it relates to recovery and the Great American Recovery. That's providing us a lot of opportunity to work across HHS. And that's exciting to me. But I'll mention just briefly a few initiatives. We recently announced $69 million in funding that will directly address the root causes of addiction, including homelessness and serious mental illness, and strengthen community safety by expanding treatment that prioritizes recovery and self-sufficiency. We also dedicated another $45 million to focus on building and strengthening recovery housing for young adults, ages 18 to 24. It's a vulnerable group and one of the largest populations struggling with addiction right now. Part of the Secretary's behavioral health agenda is a major initiative called the Streets Initiative. That initiative will, and we're still working on getting that out. One of these days, I'm gonna say it's out, but we're this close. It's a $100 million initiative. 8 communities will address addiction and homelessness. We think it will really start to solve some of the long-term issues that these communities have been struggling with for ages. And we really hope that it's a model that we can implement in other spaces as well. part of what we're also doing is engaging the faith-based communities, organizations, and the communities that they serve. Coming from the South, I understand the importance of these communities and the role that they play in helping people, number one, but also addressing addiction and mental illness in very effective ways. So we're looking to expand that collaboration with the faith-based organizations. We have stood up an Office of Faith in SAMHSA as well, which will be good partners with the HHS Office of Faith. Generally, I would say that it's a great opportunity for SAMHSA to highlight the work that we've been doing for a long time in recovery, using the platform that has been created, supporting the Secretary, supporting the President, with Ms. Burgum's leadership. We just look forward to what we can do next with, and we have some things planned, so what we can do next. Thank you.
Dr. King, can I say something? You know, I just hope that we're measuring how we're going to measure success with these as well. You know, how do we know that what's working and what's not working is important? And then how do we communicate that to the community health centers, to the CCBHCs as well? So I hope that these grants lead us somewhere. Thanks.
I'll just add to that. Functional outcomes, Senator, is something we've never evaluated in mental health. We track symptoms, not results, as was said a number of times here. So I love what you're going after here, which is not getting all mired in too much process and focusing more on outcomes. And so, you know, that's our goal here, and I appreciate your bringing that up.
Your guys' points are very well taken, and the beauty of health information technology, as burdensome as it is, it does track everything that happens. And so our BHIT initiative that SAMHSA was kind enough to conceive of and deploy with us allows us to see what has actually worked and what has actually not worked. And we will report that out not just to the community, but also to the Senate. Ken, you run policy for the Secretary. From a policy standpoint, what are the most significant levers available to HHS to improve care coordination and outcomes across mental health and substance use care?
So, Dr. Keene, I know we had worked together on interoperability regs in the first Trump administration, and something I know you're implementing now on the standards and how the data is going to flow between providers and electronic health record vendors. But the Cures Act was passed in 2016. One of the key components of that was the enforcement of information blocking, or when healthcare entities are not sharing a patient's healthcare data with other healthcare entities for one reason or another. And so when the Secretary came in and realized that it had almost been 10 years since the Cures Act was passed in 2016 and information blocking was still not being enforced, he had asked, you know, what could we do? What could we do to make sure that patients had their data when they needed it? It's very important, not only in an emergency situation, but also just for management of chronic care. So he had used his secretarial transfer authority to transfer the Office of the Inspector General $10 million to hire new attorneys and other specialists to start digging into potential cases when healthcare entities were illegally withholding information or performing information blocking. And so over the last few months, we have hired a number of new people to do that and making sure that patients have their data when they need it. It's essential for chronic care management. It's essential for behavioral health care, and it's been a main focus of the Secretary, and just really, it was one of his main goals too, and he understands how important it is of making sure patients have their data, not only for chronic care, but also for behavioral health care. So that was one of the first things he's done, and we're getting updates, and we're just making sure that patients hopefully will always have their data when they need it. I know we're working closely with your office on that as well.
Ken, if I could just say that 42 CFR, I've been a little controversial with my fellows in recovery, but I absolutely believe if we're sharing HIV AIDS data, we're sharing STD data, why in the world can't we share SUD data? And if I'm going into the emergency room unconscious and I have medications given to me by my psychiatrist that they have no knowledge of, and they give me something in the ER that could kill me because of that lack of information, that is a harm that we need to fix. And so to your point, Ken, thank you for really having this effort with the Secretary to really enforce modernization of that 42 CFR, because it's going to be crucial for truly to integrate records like we're trying to do here.
And as part of our initiative with SAMHSA, we are looking at computable consent in one of our BHIT pilots, so that the consent to move 42 CFR Part 2 data moves with the patient after they give a single, provable, verifiable consent. So Carissa, what role can EHRs play in improving care coordination between behavioral health providers, hospitals, and community service providers?
Okay, this part I get very excited about. From living it from all sides, as a pharmacist, I truly believe we're in a unique position to see where the failures are and where information slips through the cracks. Academic medicine, private healthcare. I was a deputy in Medicaid for a little while, saw it from the payer side, now get to be on the policy side, and everybody is trying to fix it. There is a tool. It's technology, not always the best. I got politely yelled at by many physicians that did not like the EMRs. Totally get it. The opportunity is in sharing that information. So as the senator pointed out, there are a lot of high-risk, high-need populations that we are kind of treating as add-ons. It's the youth. And in CCBHCs, FQHCs, there is an opportunity to support them. As a congressman talked about, there is another specialty population that we're treating as add-ons, those that are going through reentry. You put all of those together, and then you look at that we are treating mental health data, clinical information as an add-on, not being integrated, just an add-on. That absolutely is just perpetuating this issue and this problem. So under the leadership of the secretary, digging in, trying to fix, and I would say revolutionize and be innovative with the CFRs, which are very old, and how do we leverage them to help support that care coordination across. It truly is putting words into action. Somebody might put down that an individual is depressed. They put somewhere else a diagnosis code that might reflect that in a different EMR. They have then a medication that might not live in either of those, but it is in the PDMP. All of those different types of databases for medical information have been supported by grants from the federal government over the last decades. Some of them have been required by statute in different states. What hasn't been required is sharing of that information across all of those technology platforms. Thou shalts, I'm from Nebraska, and so we don't always like governmental thou shalts. What we do like is government saying, let's support you to do the right thing. Care coordination across all of the different technology platforms, across all the different data elements of somebody's medical record. Not treating these things as an add-on is how care coordination can actually occur for all of these patients. They shouldn't be an add-on anymore. It shouldn't be we're going to treat you holistically, and maybe we'll talk about your mental health. Holistic means everything.
And we're doing everything we can to move towards that. So I was told by my timekeeper that we have 30 minutes left in this roundtable. For the remaining 30 minutes, I'm going to turn it over to my colleague, Sam Cardle, who is neither from Ohio nor Utah, but he is from Minnesota. So
then we can just mute his mic.
Yeah, this is sweltering heat for him right now.
I'll suppress my accent for your sake. So thank you, Dr. Keene. And one thing I'm going to turn to for a second here is we've gotten a great job getting the national perspective, but as Congressman Kennedy was saying earlier, mental health and substance use care is highly personal, and I think that getting a perspective, not just from the federal level, but from the states is incredibly important here. So I want to start with you, Tracy. Can you tell us, when it comes in regards to mental health and substance use care, what's working in Utah that we should know about, and particularly when it comes to behavioral health IT?
Yeah, thank you so much. I think when you talk about what's working and the opportunities, you also have to talk about the challenges, which have been well established here, the data sharing, getting clarity, the room of federal leaders here. So I think knowing where the impacts are at the state level is incredibly important. And we've talked about the small providers being disconnected, not having the EHRs, not having the funds to connect to EHRs, really providing that care independently. And then also the fragmentation of the system. And we always have to remind ourselves that the state and the government solution or providers on the mental health side is just a very, very small part. And sometimes we have challenge pulling that lever on the private sector. The opportunities really are, and what's working well in Utah is that when our department became the Department of Health and Human Services in 2021, when I was appointed, we established the Division of Integrated Healthcare. Used to have a Medicaid division. In my mind, Medicaid is a lever, it's a solution. You have to be able to bring the behavioral health and physical health together and know what that primary payment lever is. We also have approval from CMS on reentry. So people leaving corrections and jails to make sure that 90 days pre-release, we're connecting them with healthcare. That's huge with people who have substance use diseases as well as behavioral health, mental health conditions. I have to talk about the opportunity that the Rural Health Transformation Program is providing to states, particularly in states like ours that have big rural frontier communities, and what that's going to mean on technology for these small providers who don't have EHRs. We're going to have an opportunity to bring them into the systems with FQHCs and using that technology. In Utah, we also have an Office of Artificial Intelligence. It's not in our department, it's in our Department of Commerce. And what's really interesting about it, well, the first regulations that they've established, guidelines they established was on behavioral health. But it's providing a forum to address regulatory issues that could stand in the way of AI and put them in the regulatory sandbox and see if we can test some AI solutions. So that's really exciting on the behavioral health side. The other thing that I'll just mention is the One Utah Health Collaboratives. We're talking about bringing together the private sector with the public sector. This is something unique in Utah. It's a nonprofit that Governor Cox established right at the start of his administration. And that's allowing both the private and public sector payers, providers to come together to deal with things of interoperability, get buy-in, not have the heavy arm of government say, you must do this, but seeing the value of bringing everybody together and establishing things like EHR systems across both sectors is really important. I also just have to bring to light the opportunity that all of us have here, particularly on the federal side, which I always mention, and it's the outcomes. The federal government has a really strong role to help us define the outcomes, as has been mentioned. Paying for strategies doesn't work. We need to know what the outcomes are, and we need the opportunity, because people don't live their lives based on federal funding streams. We need the opportunity to bring those federal funding streams together, be outcome focused, and address the needs of the population. So that's some of what's working and some of the opportunities that we can all leverage here.
Thank you, Tracy. I appreciate that. Dr. Krogan, could you tell us about Louisiana's approach to behavioral health, and how are you leveraging technology to improve outcomes in Louisiana?
Sure thing. Well, we actually have some good news to share at this panel about our reentry 1115. So there was a press conference last week with our governor and the head of Medicaid announcing that we're on track for approval later this year. So that'll be the first of this administration. And I'll come back to how we kind of work through some of those issues. But Louisiana, America's health rankings ranked us 50th again last year. It's no secret that Louisiana has its fair share of health challenges, so we usually don't get invited to panels with Utah and Ohio. But our mental health America ranked us 27th overall in terms of mental health and 32nd in terms of access to care. And I bring that up not to claim victory. In fact, quite the opposite in terms of success. I think the system very much feels broken for clinicians, certainly, and patients in Louisiana. And we spent a lot of time unpacking those two contradictions. How is our behavioral health ranking so discrepant from our overall ranking, and how does it feel so broken despite these numbers? And the short version is we think it comes down to transitions, that for folks that are in care, able to access care, they actually do overall relatively well for Louisiana, but it's the transitions between levels and sites of care that are the most disruptive. I'll just give you one quick clinical example. 3 weeks ago, I saw a woman who had just gotten out of jail, and she was on Suboxone. She told that to the provider. They didn't feel like they had enough information to continue her on her medicine, so she went through withdrawal. And then at the same time, she told me, they started me on this antipsychotic, and it worked really well for me. And I was just asking her, like, so what, do you remember the name of it? Does it start with a D? Does it start with a Z? And I was like, this is so absurd that in 2026, I'm asking her to remember the letter. Maybe the nurse mentioned it, and she heard about it. And so it's those transitions, community to jail to community, rehab to community, jail to hospital, that I think the handoff breaks. And so there's 4 things in Louisiana I'll touch on quickly that we're doing. Our Reentry 1115, our Bridge program, Project Mom, and our rural health transformation. So basically the breakthrough on reentry was able to align with the upcoming federal requirements on budget neutrality. So we're going to use APD funding, rural health transformation funding, hopefully non-deployment broadband funding at some point, and state general fund to build the IT infrastructure essentially outside of the 1115 waivers so that can be focused on providing services. And we should be the first approval in this administration and looking at Q3 this year for that to be formalized. Second big initiative is our Bridge program, which is all about getting folks linked to care and initiating care when they visit an emergency department. We would never treat someone with a heart attack, just show up, give them a brochure to a cardiology clinic and say, not start them on a medicine and hope for any different outcome, but that's unfortunately how we treat a lot of overdose visits in the ED. So we're using our managed care incentive program to set up incentives, different tiers, bronze through platinum for hospitals, and we'll reimburse them accordingly based on how much infrastructure they're able to do, but start folks on treatment and get them linked to outpatient care in the health system. Third big initiative is called Project Mom, which stands for maternal overdose mortality. In Louisiana since 2018, overdose has been the #1 cause of pregnancy-associated death. So to get a different outcome, we need a different intervention. Essentially, this is a large collaboration between our regional public health offices, our birthing hospitals, and our outpatient behavioral health providers to try to make sure no pregnant woman or postpartum woman falls through the cracks. And there's a big IT component to make that sustainable. And the last piece is how we're thinking about our rural health transformation dollars, which are incredible. One of the pillars of our program is a statewide EMR license that the state will own, that we're planning to make accessible to rural health clinics, our parish health units, hopefully even jails and prisons. And so that, I think that just changes the whole game. It changes how information flows at the clinical level, changes how the state evaluates programs in terms of being able to go to true clinical outcomes. So pretty excited for the implications of that program. So I'd say takeaway is that it's the transitions, that we think folks are falling through the cracks. And if we can improve those handoffs, we'll improve the system writ large.
Thank you. And Tia, now moving on to Ohio. I know this is an Ohio heavy panel, so I want to make sure to give you your time.
I love it.
What strategies is Ohio taking to coordinate the medical, behavioral health, and other social services?
Yeah, I think just as a reminder, how we're set up is the Department of Behavioral Health is a standalone cabinet that has a $3 billion budget. a quarter of which goes to operating our state hospitals. So largely we rely on our relationship with SAMHSA as well as the generosity of our General Assembly. And so really bringing an Epic on those 6 hospitals was a game changer for us as a business operation, right, to become a little more lean in government business and centralize those hospitals so at least we can see our patients moving through our own systems. You want me to be louder? Better? So bringing in Epic on our 6 state hospitals has allowed us to kind of practice what we preach in terms of centralizing, watching patient movement, and even identifying opportunities, though slim, for revenue making. That also opened us up to understand that, like you had shared, most of our providers, of course, have EHRs, but many of them are retrofitted or were made only so that they could be affordable to that community behavioral health provider. And so when we went into our budget efforts, we tried to look at an HIE, and it was just a lot to bring the General Assembly along, so we'll have to try again. But I think by modeling that through our hospitals, it's been pretty critical, both in learning the patient journey. The next I want to talk about is very simple in some ways, but it's about beginning with the end in mind, and that was how we built up MRSS. MRSS is Mobile Response and Stabilization Services. This is a 60-minute response for any young person, 20 and under in Ohio. It is available all through Ohio now by order of Governor DeWine. And of course, our agency couldn't afford the cost on its own, so we braided our funding with Medicaid. But what made this work was that from the day that we began MRSS in some of our rural counties with the Engage grant through SAMHSA, we had an evaluator, and we had built a simple data management system. This is literally just holding providers accountable for response time and family engagement, and then on the back end, evaluating the family experience. And we were able to calculate to the penny the cost saved to child welfare systems, emergency rooms, other healthcare providers, psychiatric inpatients, and child relinquishment. So it's one program model that, when done thoughtfully with small number of metrics, we were able to demonstrate to our General Assembly the cost savings in a business case for why they should invest to bring this statewide. And we were incredibly successful doing so. And I believe, beyond a reasonable doubt, that it was because we were so thoughtful in making sure that we were establishing ROI and outcomes from the beginning to the end. And then the last little, not as necessarily as tech savvy, but as we try to bring on our more rural areas to telehealth platforms and broadband, as we look at rural health transformation and as we look at the stigma associated in Appalachia, rural Ohio, and in our farming communities, we advanced forward with mobile opiate treatment programs. So these are 2 nondescript mobile buses that provide full health care checks, but so that folks can receive their opiate treatment, their dose for MAT, and they can do that without having to take Medicaid transportation across the state. They can pop in and pop out. We are simply now awaiting our DEA approval to be able to start operating those buses. So, I mean, if anyone around here knows anyone, it'd be really cool if we could get that approval and start that work so that folks can live, work, play, and heal in their own communities.
Thanks. That's very helpful, and thank you guys for all letting us know what the states are doing. So I think we have about 8 minutes left. So first of all, I just want to thank everybody on the panel. This is really an all-star panel. I know you all have day jobs in which you have real responsibilities and lots of things to get done, and I can't thank you enough for your generosity with your time. So what I would like to do, having heard what the other panelists have said, I would like to call on you all one by one. And in 30 seconds, if you could tell me one ask of the federal government, one ask of HHS that you would have, based on what you've heard, that would make a difference in the next 6 months to a year in the treatment of substance use disorder and mental health problems. And I'll start with you, Tracy. And my colleagues, I should say, my colleagues from ONC are writing these down. So they will be preserved for posterity.
I'm going to stick with the theme of the conference, which is really dealing with the issue of interoperability and the ability to have clear measures within the EHR systems that could be standardized throughout the country, and everyone knows what data they're pulling in and what outcomes are being measured.
To you.
Yeah,
Oh, go ahead, Dr. Krugen.
Oh, sorry. I'll add the appreciate the continued flexibility in terms of grant funding. I'm sure at some point it's a trade-off between rolling out evidence-based models at the state level versus allowing experimentation, but I feel like states have been able to do some really innovative work, so would appreciate the opportunity to innovate at the state level.
I've thought a lot about this ask because I knew you were going to ask. I'm trying to be very well behaved. I think that it's time to move some of our HHS systems to a VBR environment, value-based reimbursement, even a fiscal intermediary, so that the grant making that we're doing is not so blind. And maybe I'm only speaking for Ohio. I don't think so. But I know that we're sometimes paying for the treatment of the same people, whether or not we want to or not. And I think there are ways that both through the health information technology exchanges and a fiscal intermediary, or even some sort of just these shall be the outcomes that you are grant making for. It would be great to see us get closer to a payer reimbursement environment in grant making. So any technical assistance.
Fantastic. Patrick.
I'd like us to keep the big picture in mind to make it clear to people that this is not some esoteric, non-sexy issue, but rather it's fundamental to our public getting better writ large. You can't deal with chronic illness, heart disease, cancer, diabetes, if mental health isn't brought up to speed with its clinical care pathways to ensure that we bring the same rigor of expectation of outcomes to mental health like we do with other illnesses. That has to be our overarching goal so that we can make it clear this isn't just us managing something over here on the side with BH, which is what we've always done, that this is fundamental to our nation's health. And so with that, we just want to support your efforts, Dr. Kane and Catherine's and this administration's, because this is the moment where we finally bring BH up to speed with all other chronic illnesses. And that's what this data is going to allow us to do.
Thank you. Senator Marshall.
I think I've been pretty clear. One dashboard, one EMR, one dashboard for each chronic illness, in this case, mental health, and requiring everyone connected to the government to comply with that one dashboard that measures outcomes. And then we're going to have to pick a most favored nation, EMR, and everybody that touches the federal government has to use that one. I'm tired of Ford's not talking to Chevy and Dodge. It just doesn't work in the real world. And they promised for 20 years, 2008, and there's still no interoperability that's meaningful. Thanks.
And Catherine.
I have two, but I'll make it fast. Adopt the chronic disease model that also includes mental health. Adopt it completely across government, CMS, everywhere, because if we don't change what we're doing now that's not working, we will continue the generational decimation of families across America because it's not working now. So we need to do something. And we have this administration, which is a unicorn point in time, where we have senior people in the administration who care deeply about this because they've been individually impacted by the disease of addiction. And then the other one is the IMD 16-bed exclusion, which, Ken, don't yell at me because I bring it up a lot, but it's a temporary waiver. It prevents upstream investment. It's not scalable. So although there is a waiver, that it's not a solution to really providing more opportunities for treatment.
So I think I speak for the whole room in saying that this panel was absolutely outstanding. I can see the passion of everybody on the panel, the depth of knowledge, and I appreciate the frank and open discussion. Can we give a round of applause for our panelists? A little housekeeping. We're going to have a 10-minute break from 10:55 to 11:05. There's a bathroom out there, and there's a cafeteria with bad food as well, and coffee. And we'll be reconvening at 11:05 for an Innovation in the Field Progress Report on Behavioral Health Transformation.
Produced by the U.S. Department of Health and Human Services.